Muy buenos días, colegas. Good morning, everyone. Soy Pedro Abedillo, asesor regional de tuberculosis en la Organización Panamericana de la Salud, en la oficina de Washington, y quisiéramos darles la bienvenida a todos.
Good morning.
A esta reunión virtual,
Welcome to this regional virtual meeting, Preventive Treatment of Tuberculosis to Accelerate its Elimination. I would like to inform you that we have simultaneous interpretation in Spanish and in English, and you may choose the language you wish to listen to by using the icon in the lower part of your screen.
In English and Spanish. At the bottom of the screen, you will see a globe icon, and you can click on the interpretation globe, and you can select the language of your choice. También comentarles que, bueno, como en los webinarios previos,
I would also like to let you know that as in previous webinars, we have exceptional presenters, colleagues from the WHO and also from the national programs of TB for Brazil and Uruguay. And we want to let you know that we are going to share a link where you will find all the presentations in English and in Spanish to make it easier for you to follow the presentations. The session will be recorded, it will be shared with you, and it will be included in our webpage, so you may consult it. Without further ado, I will like to give the floor to Dennis Falson from the PAHO TB team. Thank you. Thank you very much, Pedro. Thank you for joining this meeting. I would like to let you know that during this session, we are going to talk about the current situation in preventive treatment of TB in the Americas. We will tell you which are the reasons why this treatment must be provided, what are its repercussions, and also we would like to let you know which are the current recommendations of WHO, the groups that will benefit from this, which are the risks, the means that are available today, and we will also share the study that was made with several countries, especially in my case with Brazil. And then we will close this session with the presentations of two country experiences in the search of contacts and in the preventive treatment for TB. We will now start with the current situation of preventive treatment in the Americas, and then we will talk about the upgraded and updated guidelines. We will then listen to the WHO, and then we will talk about tests for TB infection. This will be presented by Charlie Nathanson from the WHO. We will then have some time for questions and answers, which you can write on the chat or in the Q&A space. And thereafter, we will listen to the presentations for country experiences from Brazil and Uruguay, the two countries that will be presenting. Thereafter, we will also have some time for questions and answers after the country presentations, and then we will close this webinar. Very well. We shall now go on to the first presentation of this morning, made by Dr. Pedro Abedillo. Thank you so much, Francisco. Good day, good afternoon. As we were saying, we're going to provide some information about the situation of preventive treatment in the Americas, the data on the preventive treatment and its coverage, and also some information on the situation in the different countries and how they are making progress with the new systems and schedules that have been approved. You know the ambitious commitments that were reached in the high-level meeting of the United Nations meeting in New York. You know that we have some numeric goals which were established, and countries committed to offer very ambitious coverage of treatment, quality treatment, 90% by 2027. Also, coverage of treatment for people who have been diagnosed with rapid diagnostic tests, and also a very ambitious goal for preventive treatment. 90% of people that are at high risk should receive preventive treatment for TB. If we wish to improve treatment, we need to improve case detection, and as we have said, we need to increase the passive search for cases and also a systematic search, which we carry out in some populations which are more affected, have a higher TB existence, and also we know that there are some hotspots where TB is concentrated. And we are now trying to meet these two first goals and also coverage for preventive treatment. In order to meet these ambitious goals, we are proposing to work in 5 priority areas, which have been discussed and agreed with the countries that are part of the program in the meeting of chiefs of programs, which are the main areas of our work. We are trying to change the paradigm, and we know that right now we have new technologies, new techniques and technologies, and this can help us make progress in this effort. For this purpose, we need to push for an active search for vulnerable populations and hotspots, and also for infection by TB. So the first goal is to close the detection gap. We have to increase active search in the most vulnerable populations, which are the most affected ones, which is where the epidemic is concentrated. For that, we need to have more detailed tools, quick molecular tests, and quick analysis. We also need to have robust information systems. We need to strengthen the analysis that we carry out. Robust information systems to support the measures that have been implemented. And in this webinar, we are looking for contacts and preventive treatment. We also know that if we want to put an end to TB, we need to focus on multi-sectoral approaches and to take into account the social aspects. These are the agreements we reached in the regional meeting for TPT in Rio de Janeiro last year. We discussed all these commitments of the political declaration at the UN, and we discussed how to ensure the integration of the new technologies And we also included some concrete goals in the region. We reached the agreement that all countries by 2024 should have national plans for the expansion of active search. And we also proposed some preventive treatment, and we agreed that by 2024, all the countries will have plans and figured out the cost to carry this out in the risk groups. And we also said that by 2024, all countries will have implemented schedules. This graph, which you have already seen, is what we prepared when we were developing the plan for TPT, and you will see how different interventions would have an impact in the decrease of TB in the population. And you will see what will happen when we expand the search for contacts and the infection by TB. And this is what resulted in a greatest reduction of TB. So this was much more effective than just looking for search and treatment. We have already discussed this in the past, and Dr. Dennis will go into details today. We know that the investment in the testing and treatment is cost effective. We know that it will allow us to decrease the incidence and mortality more quickly, and it also offers a better return for each dollar invested. We have also said that we need to integrate active search and preventive treatment. The search is the first step. Look for active TB diseases, and if there is, then we have to provide treatment. And this is a fundamental intervention. We need to cut the transmission chain, and this is not being used properly for the time being. At the right, you will see in which populations we are recommending active search, and this with regard to the epidemiological situation of each country. And in the right column, you will see in green which are the populations for which we have WHO recommendations, where in addition to systematic search, we should carry out active treatment for TB. This will also be clear in the presentation that we will have in a minute. And we will also tell you what is the situation in the region. This is a study that we carried out in October last year. We measured the guidelines, the policies, and we analyzed which risk groups, which vulnerable groups were recommended for preventive treatment. 18 countries provided their information to us, and we are talking about contacts of all ages, people with HIV, people with diabetes, and also other risk groups who have structural risk, homeless people, and also health staff. In red, you will see the groups that were not included. We did not include contacts with TBDR, and this information is for the year 2020. We know that many countries are studying the new recommendations, but in any case, in contacts with drug-resistant TB, these are included, and some countries are informing us that they're starting work on these groups. We also know that many guidelines look for preventive treatment in many of the vulnerable groups, but in the practice, we know that this is not truly happening. What you can see here is the situation in the region as far as the search for contacts and preventive treatment for all ages from 2019 to 2023. You can see how this has evolved. The yellow column shows the number of contacts. In green, you see what percentage of these contacts have been examined, and in blue, how many have initiated treatment. As you can see, there is a gap in the search of contacts. In 2023, 67% of contacts were being researched, and we must take into account that the number of contacts that are reported may be lower than the real number. In some of the countries that we visited, we saw that the number of contacts that are recorded is lower than the real number. The information system sometimes does not allow us to have the number of contacts, and sometimes some countries only record the contacts that can be reached. If some contacts cannot be researched because they cannot go to the services, because other measures need to be taken in order to bring them closer to the research centers, those contacts are not counted. So what I'm trying to say is that the gap may be even greater than what we see here. And the other important gap that we have is the beginning of preventive treatment. 13% of all contacts of all ages are starting TPT.
Next slide, please. Here you can see the coverage for the investigation of contacts. On the left, you have the investigation of contacts. On the right, have the countries where sometimes it's much higher, more countries with adherence, and some countries are able to reach almost 90% or 80%. So countries need to analyze the situation, discuss the reality they're facing, and the percentage may be high because the number of certified contacts were not found, as we were speaking earlier, and decide what should be done. Later on, we're going to see that the contacts, that a high percentage of the contacts will develop the disease, and we therefore need to locate, investigate, and begin preventive treatment in those contacts. Here you have the indicators that are being monitored and that are requested in WHO's annual information system. The amount of preventive treatment. There are many countries that report this data. It's a cascade of data from countries that report all the data pertaining to contacts, whether there is beginning preventive treatment, and there's a gap between screened and those that begin preventive treatment. We also will see the countries from Uruguay and Brazil, how they are dealing with the treatment scheme and how they are dealing with the systems that have been agreed to. So as I was saying earlier, there's a loss of people throughout the cascade. We have many opportunities for improvement, for ensuring that these people receive preventive treatment and develop a program for that. Here on this slide, you won't look at the specific data, but it's just to give you an idea of the country reporting, the various indicators. In yellow, all the contacts that have been notified, the green, the ones screened, in blue that began preventive treatment, and then in pink, those that completed TPT. So you can see the reporting problems that exist for each country in the blank spaces. The blank spaces are years and in which the country did not report, the year in which they did not report. So what we need to do now is strengthen this record and the analysis of the information. Some countries have no system for recording the contact and the beginning of preventive treatment. Some countries don't compile information on those treated, and Dr. Dennis will tell us some of the tools the WHO now has available to be able to strengthen the recording and analysis of this information. Here, this is the cascade of preventive treatment, but focusing on those under age 5, contacts that are under the age of 5. There may be some inconsistencies in reports over the years because of the impact of COVID and also because of the fact that some countries may not have reported or changed the way they reported in certain years. You can see here that the coverage of investigation of contact, particularly the coverage of preventive treatment, is much higher when we look at each of the ages, and it reflects the priority countries are putting on this group. This is important need to initiate treatment. Here you see the contact for those under age 5. The previous one was all ages, but this is under 5. And here you can see that there are many more white spaces. Some countries notify for some years, but others not. There's a great deal of inconsistency reported. Of the 26 countries that regionally report cases, 18 approximately reported screening, and only 15 reported about starting preventive treatment in this age group. And here you'll see what I was talking about earlier, the looking for context to find people with active disease, the outcome of their result of context for all ages from 22 and 23. As you can see, only 4% of the country reported how many cases of tuberculosis were found as a result of context. This is a significant figure. It tells us the importance of how important it is to look for these contacts, search for these contacts. And here you see the indicator that we monitor annually. It's the beginning of preventive treatment of people who have HIV. This is data from 17 countries who reported on 2023. In blue, you have those with HIV, and you see there's a significant gap. Only 35% who elected to have the treatment received the preventive treatment in 2023. We see that there's still a lot of challenges. There are many myths and beliefs about preventive treatment amongst this population. And I did want to let you know that we will have a special webinar on how to provide preventive treatment to HIV patients so that we can continue discussing jointly what else we can do to improve the results for this indicator and this population group, which is important to make sure they get treatment. Here you can see what the countries reported on the diagnostic tests for TB infection last year. In blue, most of the countries reported that they're using the IGRA and the tuberculin test in most countries. So although we know the use of IGRA is not widespread throughout the region, most of the countries that report its use are more in the private sector or in a hospital context, and mainly devoted to health staff or people who have HIV or other immunodeficiencies. So it's not widespread. It's not used in a widespread manner for the contact of tuberculosis cases. Later on, we'll have a presentation where you'll be able to see in greater detail the different types of diagnostic tests being used in the region. Here, you see a slide of how the region has moved forward in implementing the systems that we have agreed to for preventive treatment, the 3HP treatment, 3 months of isoniazid with rifapentine, and 18 countries reported the use of it in 2024, and 19 countries have now introduced this preventive treatment system. We know that last year, using 1HP and 3HP method. We don't yet have data on the coverage and the use, just a report that it was being used. But later on, we will hear from our colleagues in Brazil, and they'll tell us how they've moved forward in applying this treatment system and the coverage in Brazil. And this is the last slide on regional data on the use of preventive treatment in context of cases that have tuberculosis that's resistant to rifampicin and MDR. As you saw before in our analysis of the policies, in each country, no country was using it, but 10 countries last year now reported that they are using this treatment. So we know the countries don't do this on a widespread manner, but they are beginning to start this preventive treatment system of 6 months using levofloxacin. And Dennis will talk a bit to you more about the recommendations WHO has for the use of this treatment system that is more effective. And then the last slide, to remind you that the webinars we're organizing, you can find them on the page devoted to this regional initiative to accelerate a move towards elimination of TB. As you know, we started this initiative to accelerate the implementation of any innovation, and we're focusing on the active search for tuberculosis patients with the use of artificial intelligence and preventive treatment. And we're now developing new resources to be able to support the countries, in addition to all the material that appears in the web page. Any new material that we develop or from WHO or the experience of other countries in the search for active cases, we will put this on the webpage, and we are now working on the use of X-rays to determine active patients. Let me also remind you that some months ago, WHO launched the virtual course on preventive treatment based on the guidelines and the operational manual for preventive treatment. It's been translated into Spanish. There are close to 500 certificates that have now been issued, and we invite you to take note of the fact that you can use this and distribute the information about it amongst your networks, your contacts, so that they can take the course. With this, I would like to draw some final conclusions. I think we've seen a summary of the situation in the region. There's still a lot of lost opportunities. There are a lot of room for improvement, significant improvement, to implement these strategies, which we know are key to avoiding new infection and cut the transmission chain and move towards the elimination of tuberculosis. These are cost-effective interventions. And in order to do this, we need to continue moving forward in increasing 100% of coverage of investigation of contacts and provide preventive treatment. But we have to work on other groups as well. There's some countries that focus exclusively on contacts or on children under the age of 10, but that's not enough. We need to expand the ages that we try to provide preventive treatment to, and find contacts in that area. We also need to move forward in contacting cases of resistant tuberculosis and other risk groups. That we will in the future have some special regional webinars to address these ages groups, and not only HIV, but also on how to provide preventive treatment on those who have been deprived of their freedom, because I know there's an interest in that in the region. We also have new tools that could facilitate the process for implementive preventive treatment. Or the X-rays in the hospital has also been expanded in use in the region, and we have other systems based on rifampicin and the new use of levofloxacin. And I would like to remind you that we have to work in a comprehensive and integrated way with other programs, other services, other sectors in order to strengthen the search for contacts to provide preventive treatment. We cannot do this only through the tuberculosis programs. We need to work with these other services, first care, primary health care, maternal and child care, immunization with HIV as well, with the private sector, and with the community itself. We've also seen that it's very important to continue strengthening the recording and analysis of information. There's still gaps in information that prevent us from finding out how we're implementing this and what our results are. And we do have some tools, which Dennis will talk to you about, that are available to the countries to be able to improve this. And I will conclude my presentation. As I said earlier, we'll see these WHO guidelines and the recommendations for preventive treatment for diagnosis of TB infections. And then following that, we'll have the experience of 2 countries that have been successful in preventive treatment. They're not the only ones, but these are the experiences we have selected to present at this webinar. With this, I conclude. Thank you very much. Thank you, Dr. Abello, for that excellent presentation. Let us now move on to the next topic with Dr. Dennis Falzon, WHO recommendations and guidance on TB preventive treatment.
Hello. So thank you very much, colleagues from the PAHO region. I'm very pleased to have this opportunity to discuss with you on this topic. It's really encouraging to see such a huge participation in this webinar, and I hope that the slides that I will present will improve your knowledge and maybe awareness about some of the things going out on TB preventive treatment. I hope you can see my first slide. Is that okay? Does it show well?
Yes, it's okay.
Okay. So yeah, unfortunately, I will have to speak in English because I don't master the Spanish language. But let me first introduce myself. I'm a team lead here on TB prevention at the World Health Organization's head office, the Global Tuberculosis Program, which deals with tuberculosis as a department here at our headquarters. So the subject of my presentation, following this excellent overview that Pedro has provided, focuses particularly on the new guidelines and the handbook and some of the associated tools. I think Pedro has already alluded to some of them. So I think Pedro has already shown this slide. I just want to, again, underline the ambitious nature of these targets. It's important that they are ambitious because they come at a period after the COVID pandemic, particularly where there has been a very big disruption in the TB services globally. And it's important that we come back on track to make sure that we maximize the effect of interventions of prevention and treatment for people at risk of HIV, of the TB. And you can see I highlighted in this the target, which is specifically sort of pertinent to discussion today about coverage. So 90% coverage of TPT to people who need it by 2027. So it's a bit different from how it was in 2018 because it's a percentage coverage, which makes it even more ambitious and which translates to about 45 million people globally between last year and 2027 to receive TPT, including household contacts and people living with HIV. Of course, to these one would need to add other risk groups who may be less numerous, but who are equally needy of TPT. Yeah. So going to through the guidelines of TPT. So this is a track. It's not a complete chronology of the guidelines development by WHO, but it shows the first sort of grouping of recommendations into guidelines. There were in the individual recommendations dispersed in different documents between 2015, and then they came together 2015 into one document that was expanded later to include also the management of TB infection in countries with a large burden of TB. And then in 2020, we produced the guidelines with accompanying handbook, the first edition of these guidelines that came out as part of this modular series of guidelines that we have on our knowledge sharing platform. And we will be releasing very soon, in a few days' time, the updated second edition of the guidelines and the accompanying operational handbook. So we hope that by early next week, we will have the English version of the two documents available and distributed via our via newsflash. So you will see this coming up soon. So the 2024 consolidated guidelines includes in it 21 recommendations on 4 critical steps of the TB preventive cascade. The first step is to identify people at risk. The second one is to screen for TB and rule out TB, testing for TB infection, and selecting the TPT regimen. There's also other comments on monitoring and evaluation and the research gaps. So, so the guidelines themselves represent the body of sort of evidence that has been reviewed, the latest evidence, and translated into evidence-based recommendations with a statement about the strength of the recommendations. They can be strong or conditional, as well as the quality of the evidence on which they are based. And the evidence can go from high quality or high certainty in the estimates of effect to very low, which sometimes is resorted to. I just maybe at this point highlight that the difference between the guidelines and the handbook is that the handbook is more of a practical document meant for implementation, but the recommendations themselves are mentioned in the handbook. But for people who are really interested in how the recommendations were developed and on which evidence they rest, then you would need to go on the guidelines and the associated annexes that go with it. If you are more interested on, as many implementers would be, on the practicalities of implementing the recommendations, then the handbook is a more suitable document to follow. So just to highlight the changes that there will be in the second edition of the guidelines that's imminent in production. So there is a recommendation on TPT for MDR-TB that has been now updated. So the recommendation will come to it later on. It is more specific to the drug, to levofloxacin now than the previous one. There are 3 recommendations on newly recommended screening tools that were already in a previous guidelines that came out 3 years ago on TB screening, these orange guidelines, and 2 other recommendations on screening for household contacts and other risk groups from the same guidelines that were incorporated, because we wanted the consolidated TPT guidelines to, in order to follow those 4 steps right in the cascade, that they will be more or less complete and standalone. Then likewise, we have imported 1 recommendation on the new antigen-based tests of TB infection, which were issued by WHO in 2022, was also added over there. And then there were some changes to 1 recommendation to make them a bit more easy to follow in terms of TPT for people with HIV. In addition to that, there were previous recommendations on the treatment of TPT that was split into 2, 1 for regimens that are strongly recommended, and then another one for alternative regimens that are conditionally recommended, particularly the 4-month rifampicin and the 1 month of daily isoniazid and rifampicin. Then there were 2 recommendations that were misleading or outdated that were withdrawn, and these relate to the negative recommendations that existed previously on giving TPT and testing for TB infection systematically in people with diabetes, people who use alcohol, tobacco smokers, and people who are underweight. So in these populations, the evidence that exists at this point in time does not warrant that there is a negative recommendation, but it's more that in these populations by themselves, the systematic recommendation cannot be entertained one way or the other, right? So, and we did this because there were a number of misunderstandings, I think, in the way that this recommendation was interpreted. So, for instance, if you have someone who's a contact or person with HIV who had one of these other conditions, sometimes TPT was being refused in these people, and this was it went against the intention of the original recommendation. There was also an older recommendation about the use of long-term use of TPT in people with HIV in high TB transmitting settings, where there was a recommendation to give 36 months of isoniazid, and this recommendation has been withdrawn because it is a bit outmoded now. Regimens with monotherapy of isoniazid for 6 months or more are still recommended, of course, but these ideally would be replaced with other newer, shorter treatments that are now available, particularly the rifampicin-based regimen. Then we updated as well the text of some recommendations and research gaps and the references. So you'll find a more complete sort of list in the new guidelines. Okay, so just to go over very quickly the recommendations. So I'm not going to stay reading out the recommendations themselves, but you see them listed over here. Those that have an asterisk against them are the recommendations that are strongly recommended. So in strongly recommended, strong recommendations mean usually that the both the providers and the persons who would be receiving these recommended interventions would, in most instances, want to have that recommendation, but they might need some work to interpret the recommendation, to explain exactly what they mean. So we see that in people living with HIV, in adolescents and adults, this is strongly recommended. In infants who are under 12 with HIV and who are in contact with TB, this is strongly recommended. Then there are other situations like children aged 12 over or 12 months in high TB transmission settings, and children who have successfully completed treatment for TB might also be given TPT. Sorry. Then there are the household contacts, or children under 5 years, so are strongly recommended over there, and individuals older than that who are contacts would also be recommended. And then exposure to MDR-TB would make another group where the recommendation would be given. So then there are other risk groups in whom the TPT is recommended, and you have them over there, and then you have other groups in whom the recommendation is applicable but conditional, namely people deprived of liberty, health workers, immigrants from countries with higher TB burden, homeless people, and people who use drugs. As you see, I dashed out now the older recommendation, which was negative, as I have mentioned before. Then in terms of screening for TB and ruling out TB, this is a usual accompaniment of a lot of activities intended to improve the access of TPT. It's the first point, right, after identifying the populations. And again, we have, I point you over there to those guidelines that came out 3 years ago, and we have imported those recommendations and added them to the ones that existed before. I think important to note here the addition of new tools for screening, right? Particularly C-reactive protein and molecular WHO recommended rapid diagnostic tests. These are important. Associated with these as well and with chest X-ray is the recommendation to use as well computer-aided detection of TB. So it has not been put as a specific recommendation, included a specific recommendation here, but it is also, of course, part of our recommendation. Yes, and the list continues with other recommendations that were there before. Okay, I'm showing here as well for those of household contacts of pulmonary TB and other risk groups. Okay, so for the test of TB infections, so again, we have imported this recommendation on new antigen-based skin tests that have now become available. There are 3 products. I think my colleague Charlie will present later on and give you much more details on this. So in addition to the TST and IGRA, now these new tests of TB infection can also be employed. Just to highlight that tests of TB infection, okay, is not required to start TPT in people with HIV and contacts under 5 years of age. Okay, and then is the last step in the cascade is the selection of the TPT options. So over here, as I mentioned before, there's one option that has been dropped. This 36 months of daily isoniazid. This has not been particularly for the countries of PAHO is not particularly applicable. It was applicable only for very small, for very particular settings where there was heavy continued transmission. And even those settings, it has now probably been superseded by other options that employ shorter regimens. And then we've added this other recommendation on the 6 months of daily levofloxacin for people exposed to multidrug or rifampicin-resistant TB. So just to put in perspective the previous recommendation, right, which was a conditional one, so it was really about selected high-risk contacts. It may be considered based on individual risk assessment, sound clinical justification, with a new emphasis now and the wording of a strong recommendation that 6 months of daily levofloxacin should be used as TB preventive treatment. So this recommendation, and you will see more in the guidelines and the annexes of the guidelines, has been based on the results of 2 important clinical trials that were completed last year and which showed a significant benefit for people of all ages, right, in 2 very different settings. Similar estimates of decline in risk in children and adults and adolescents who were given 6 months of levofloxacin compared to a placebo. So very well conducted trials, right? So reliable evidence, which encouraged our guideline development group which met in December last year to issue this recommendation. Okay, so the operational handbook, just to give you a bit of highlights on the handbook itself. So the handbook will include a number of interesting things as well that will be, we hope that you will find it very helpful. It's gone through repeated processes of review. We have had a lot of input from top experts in the field and people who are at country level and who understand programs to make sure that they have a practical application to programs. So you will find some helpful graphics. So this is one of them depicting, I think it's already been actually shown by Pedro in another way, about groups in whom there is a recommendation to do both screening and TPT. So you'll see them in that overlapping segment of the Venn diagram over here. And then there are other groups in whom TPT is not yet recommended. Other than that, we have a number of other changes. So there is a revised weight band drug dosing for TPT regimens. There's updated screening and TPT algorithms. There's the prevention and management of adverse drug reactions, that chapter which was there before in the first edition that has been updated. Then we have some country best practices on TPT implementation and other practical information and annexes. So you will find a revised format of the weight band dosing for the TPT regimen, starting from a very low weight corresponding to newborns from about 3-4 kilos, and then it continues for all the other weights. And you will find that the calculations based on the most commonly available formulations of the drugs. So for instance, for 6H or 9H, then you're looking at also options to dose in terms of tablets of 100 milligram isoniazid dispersible in fractions of half a tablet, and likewise for the other drugs. So this I hope will be a bit clearer compared to the previous table that existed in the other handbook from 2020, which was sometimes a bit tricky to understand and also referred to milligram per kilo body weight, which has now been simplified and no longer features in these tables. So you see them here for the old regimens, or not the old regimens, but the sort of regimens based on isoniazid and rifampicin. And then for the rifampicin containing regimens and the levofloxacin, you will find them here. There is a different weight band dosing here because this has been adjusted on and based on these harmonized weight bands that WHO is implementing across different disease areas. And you can see over here, and these are resulting from much of pharmacokinetic simulations for the 3HP and the 6LFX. So I think the important point to note here is that now 3HP is recommended below the age of 2 years. So until the 2020 guidelines, they were only until the age of, from the age of 2 years. Now you can see they go down to their use in humans. The first two weight bands are modified by age as well, so this is the only exception where otherwise the weight band dosing is regardless of age. But there is a cutoff in the first group of 3 months, and this. So you see that this is applicable for both 3HP and 6LFX. So again, the important thing to remember as well is that there are dispersible formulations of rifampicin, isoniazid, as well as levofloxacin, and these would facilitate the administration of all of these regimens to children of this age. But of course, the use of crushed oil the disposable available to them. There are some changes items. These are reflect the regulations well the so we have this from which the ships that they had come forward or care primary healthcare and the capacity of nurses over time to improve capacity to be able to take on more and more components of TB preventive treatment in their hands into and even the possibility now to start and prescribe PPT and to monitor their treatment. So I think this is a a very good example and could serve, we hope, as a model as well for other countries to follow. And for the annexes, we have included as well in the first annex, the investment case. Pedro has already introduced this. There's another annex which groups together the costing considerations for PMTPT. Then the final annex, Annex 6, is about the data variables to be collected for contact investigation. This has been also a common question that we received from users. And then we have the web annexes, the first one of which will give you more detail on the background of those modeling and simulations that were done to inform the revised weight band dosing for 3HP and 6-LFA. Okay, so to jump to the investment case, so maybe to add a few more slides to the one that Pedro had already shown you. The investment case was an exercise that was conducted by our team and that was launched in March this year in World TB Day. It is a document that it's a short document, okay, but there was a lot of work that has been done. Brazil, again, was the country in your region that had contributed much to this. And there will be some papers that will be coming out shortly, which will give the background to this work. But we position this document as a key advocacy tool for situations where ministries of health want to build arguments about why should we do prevention, right? Why don't we just focus on TB treating the patients that we know about and the people who come with disease. So this, I think, makes a strong case of why it is important that we invest in screening and TPT. You can see over here, I'm not going to go over a lot of numbers for you, but you can see strong arguments over here. So for situations like, for instance, Kenya and South Africa, if we were investing in screening and preventive treatment, by 2050, we will have saved more than 1 million people in each of these countries from developing TB. And there are important also returns on investment. For each dollar invested, you can have up to $39 returns just by investing in these interventions. We looked at different populations. There were, of course, people living with HIV and household contact were modeled in all countries, but then people deprived of liberty, for instance, were the case on which we focused in Brazil, and then Georgia was looking at people with injected drugs use and people living in high-burden communities in the other countries. And you can see that one of the key messages coming out as well is that TB screening plus TPT. So there is TB screening by itself already gives you reductions in national TB incidence, but the TPT has an additional benefit that is perceptible. And you can see in these graphics showing the traits that you would expect to have, even with a minimal intervention, in the sense that you would be doing an intervention only for the first 3 years. You would be expecting that you will have a perceptible sort of influence on incidence, which is long-standing. And you see much of the drop is already done by 2035, but the near future, so don't need to wait until 2050 to start reaping the benefits. And we can see some reductions of the order of 1/2 of the original incidence occurring. Okay. Another one is about cost effectiveness, which is a common question, and you can see that again the investments were found to be cost effective. The cost per TB episode preventive were modest, okay, and cost per daily averted were well below what is considered the willingness to pay threshold. And it was cost saving for all 4 countries in terms of the societal perspective. So again, the idea of the investment case is to raise awareness among the public and government of the true costs of TB, first of all, and also the benefits of screening and TPT, and to adequate for appropriate resources to accelerate the implementation of TB screening and TPT in key risk groups. Okay, so the other thing I wanted to highlight is about our knowledge sharing platform. So you may be aware of this KSP that we have launched 3 years ago. There's an increasing amount of documents now that are in Spanish. There will be also ones in Portuguese very shortly. And I invite you to go there to find our guidelines as well as our handbooks and also the training manuals that the training sort of catalogs that are available. And I think Pedro has already shown us the one in Spanish for TPT. Another key tool is the Prevent TB app, which is also available in Spanish and Portuguese. And this app was launched by WHO originally about 7 years ago. It has been completely upgraded since then. The Prevent TB app is intended to show and display how data collection and management of data collection for screening and TPT can be done in programs. It is not meant that all programs will adopt this tool, but it is really meant as a demo to show countries how they can collect these data, what variables they need, how they can then generate indicators and display them on a dashboard, etc. So some countries have been using the tool itself, though there is an option if you want to install the tool. What is available online from that link that I'm giving you here is a demo option, but if you want to take the tool and start to apply it, that is also a possibility. I think there were a few countries in the PAHO region that were already interested and started taking the first steps to do this, but also other countries where they already have invested in electronic systems for TB patients want to use the same sort of framework for their work on prevention, and this is possible. And we're also doing a module for the tracker version of the DHIS2 TB module, which will include these variables in them so that if people are using already DHIS2, then they can also benefit from the preventive part of it. Okay, so this is the knowledge sharing platform again, so you can access the site from here, and then you will also be able to access it via your mobile phones. There will also be a soon Spanish version of this available for the mobile. Okay, so with that, I think I came to the end of my presentation. But before I finish, I would really like to thank once more all of you for joining this discussion, for PAHO for inviting us from there, to all the national TB and HIV programs that have provided the information that I have given, people affected by TB guideline groups, my immediate colleagues over here, Avinash, Saskia, and Matteo in particular, then the donors who have supported our work, USAID, CDC, Global Fund, Gates Foundation, and others, and many other experts. So with that, I would invite you to, if there are questions, to post them in the chat, or else to put them in when there is time for discussion. Okay, so I hand back over to Francisco and Pedro to guide us on the next steps. Thanks.
Thank you very much, Dennis, for the presentation and for your support. La siguiente presentación, bueno, quisiera, antes de dar paso a nuestro colega Michael, agradecer nuevamente a todos los participantes por atender a esta convocatoria. Llevamos 500 personas conectadas hasta el momento. Comentarles nuevamente que el enlace con las presentaciones, tanto en inglés y en español, se encuentran en el chat. Allí ustedes pueden acceder y descargar las presentaciones. También comentarles que hasta el momento entonces hemos visto el panorama regional sobre cómo está el tratamiento preventivo de tuberculosis. Acabamos de ver sobre las recomendaciones actualizadas de OMS en relación con el tratamiento preventivo. Y la siguiente presentación va a abordar lo concerniente a las pruebas para detectar la infección por Mycobacterium tuberculosis. Esta presentación está a cargo de nuestro colega Michael Nathanson de OMS. Charlie Nathanson de OMS. Please, Charlie, go ahead.
Thank you very much. I didn't follow that fully. My Spanish is very poor, but I would start to say hola and hello, Pau. I will present something. I will just project my screen. That was wrong. Is that visible? Can you
Yes.
see the screen in full screen mode?
Yes.
Very good. So, good morning. Hola. Carl Michael Nathanson, or Charlie is my name, and I work in the diagnostics unit in the Global TB program in WHO HQ in Geneva. So I'm going to present the recommendations that WHO has on the diagnosis of TB infection, as well as the operational handbook that accompanied this guideline. I'd also like just to send a thank you to my colleague Alexei Korobitsin, who provided most of the slides that I'm presenting here today. Anyway, first things first. One of WHO's core functions is to develop guidelines. And for the Global TB program, this takes up a lot of our time here in Geneva. Diagnostics is, as you're surely very familiar with, critical in order to detect disease and to initiate correct treatment. And this goes, of course, for something like TB infection as well. So the WHO process for developing guidelines follows this very strict process called the grading of recommendations, assessment, development, and evaluation or grade process. It follows a structured way where you start with a systematic search for evidence, including published and unpublished literature, personal communications, and other ways to collect evidence related to your question. Following this search and collection of evidence, you move on to assessing the evidence and grade its certainty in a systematic way. And finally, the evidence is transformed into recommendations, which will include not only test accuracy, but also end users' views, economic aspects, feasibility to implement, and acceptability among patients and clients. So, to the TB infection tests. We issue recommendations when new evidence emerges that may affect the management of TB. We gather all the recommendations in different consolidated guidelines, as you might have heard from Dennis already. So there are modules for the different topics. We have for prevention and for screening, and this one, the module 3 for diagnosis, and then for treatment, children and adolescents, and comorbidities. Each module is accompanied by an operational handbook, and that provides practical considerations on how to implement the recommendations provided in the guidelines. So the latest guidelines for TB infection tests were published in 2022, and it's a consolidation of recommendations made from 2011 and onwards. And I'll talk a bit about these recommendations and the handbook in this presentation. So here is where you find the consolidated guidelines, the QR code you can copy if you want. The consolidation that was published in 2022, that includes recommendations made in 2011, in 2018, and also outcomes from a technical advisory group meeting in 2021, and also finally the latest recommendations on TB antigen skin tests from 2022. So in 2011, the traditional TST, the tuberculin skin test, and the 3 interferon gamma release assays from QIAGEN called the quantiferon gold and the quantiferon gold in tube, as well as the Oxford Immunotech T-spot TB. They were assessed by an expert group to be used for the diagnosis of TB disease. So these recommendations were updated for the use of the same tests to detect TB infection in 2018. And then a technical advisory group meeting in 2021 included 2 additional IGRA tests in this class. And then finally, a guideline development group was held in 2022 and resulted in recommendations on TB antigen skin tests to diagnose TB infection. So what does these recommendations say? Let's go to them. We start here in the beginning in 2011. The expert meeting held assessed then the TS team, as I mentioned, and the existing IGRAs listed here to diagnose TB disease. So in this case, they were actually focusing on the disease, not infection. The outcome of the meeting was a recommendation. The interferon gamma release assay, the IGRAS, and the tuberculin skin test, the TST, should not be used in low and middle income countries for the diagnosis of pulmonary or extrapulmonary TB, or for the diagnostic workup of adults, including people living with HIV with presumed active TB in these settings mentioned above. So this is a strong recommendation, which means that it reflects a high level of confidence that the desirable effects of an intervention outweighs the undesirable effects. And it also implies that most informed patients would choose the recommended intervention. For clinicians, it means that most patients should receive the recommended intervention. And for policymakers, it suggests that the recommendation can be adopted as policy in most situations. Now, this is, of course, a negative recommendation, so it turns the things upside down, but the same criteria are applicable. It's also important to notice that the evidence that was reviewed only concerned the 3 IGRAs and the TST, and that the assessment was focused on diagnosis of TB disease of people of more than 15 years of age in low and middle income countries. So the recommendations in themselves do have a little bit limited scope. So in 2017, there were new evidence that had emerged, and a guideline development group was held to assess the use of the TSTs and the IGRAs for diagnosis of TB infection. So here we come into TB infection. The TST test and the quantiferon TB gold in tube, which was a slightly updated version of the previously mentioned quantiferon test, as well as the TB spot TB. These were evaluated, and they resulted in one recommendation, saying that either a TST or an IGRA can be used to test for TB infection. This was also a strong recommendation, though the evidence was of very low certainty. And the strong recommendation means that the previous criteria I mentioned, they still apply. So there was strong in this specific recommendation, the guideline development group meeting. There was strong evidence that one test should not be preferred to another. There was no evidence for this, and that countries need to take operational considerations when deciding what to use. Considerations for subpopulations were not made, but in the WHO consolidated guideline, that module 1, the prevention that Dennis has just mentioned, you find recommendations on how to prioritize in specific settings. So this is one of the other consolidated guidelines that you find in the knowledge sharing platform, of course. Anyway, so more evidence was produced by researchers and others, and in 2021, WHO convened a technical advisory group, which is you could say a step below a guideline development group. And they reviewed evidence for 2 new IGRAs, the one-tie test from China, as well as a second update of the quantiferon test called Gold Plus. The outcome of this TAG meeting was that the recommendations was a recommendation to include these 2 tests in the IGRA class of tests, meaning that the recommendations I just mentioned in the previous slide apply also to these 2 tests. Here I think I should mention that all the IGRAs, they require a well-functioning laboratory and well-trained staff, hence can be more difficult and costly to implement than the TST test. But on the other hand, they are based on the MTB antigens and are not affected by prior BCG vaccination. So the tests, the IGRAs, are more specific than the simpler and cheaper TST. Now we come to the latest development in recommendations for TB infection tests. A guideline development group meeting was held in 2022 and resulted in a recommendation for the TB antigen skin tests. So these tests, they use recombinant MTB antigens and are performed in vivo in the same way as the TST test. 3 tests were evaluated, the CyTB from India, and the Diaskin test from Russia, and the CTST from China. They were all found to be good tests for detecting TB infection, and the GDG recommended that Mycobacterium tuberculosis antigen-based skin tests, or as we abbreviated TBSTs, may be used to test for TB infection. It was a conditional recommendation for the intervention, and it was very low certainty of the evidence. And this means that the desirable effect probably outweighs the undesirable effects, but there is less certainty of that. It also means that different choices may be appropriate for different patients based on the value and their preferences. And specifically for clinicians, it requires a more careful consideration of individual circumstances and shared decision-making when deciding what test to use. And finally, for policymakers, it may require substantial debate and stakeholder involvement before implementation as a policy in your country. So little evidence was found for subgroups, but the guideline development group decided to extrapolate this recommendation I just mentioned to people living with HIV, to children under 18, and also to people who was vaccinated with the BCG vaccine. Furthermore, they didn't find any safety concerns. The GDG also concluded that the use of the TBST, that is these tests I'm talking about, the TB antigen skin tests, can be cost-saving in some settings, but the decision to adopt the test must be evaluated and approved by regulatory agencies before implementation. Now, the WHO pre-qualification team, the PQ team, is presently working on a routine to evaluate TBSTs, but the first test has not yet passed this process. Though the CyTB, the Indian test, was recently recommended by the expert review panel of the Global Fund and can therefore be purchased by using your Global Fund grants if you have the like. Right, so let's jump to the operational handbook that accompanies the guidelines. You find it here on the QR code or beyond the QR code. So the handbook comprises 4 chapters. The first, introduction. The second chapter provides a model algorithm. The third is a description of the different classes of TB infection tests that are recommended by WHO. As well as specifics for each test included in the various classes. And the fourth chapter provides some programmatic considerations for implementation of TB infection tests. 2 annexes. They also give detailed descriptions on how to perform the skin tests and the IGRAS. To the model algorithm, that it should be seen as a guide on how to include TB infection testing in your diagnostic cascade. So it's a generic algorithm that should be adopted to your country context. In principle, you rule out TB disease before you test for TB infection. The ruling out is, of course, not always straightforward, but it's necessary since the detection of TB disease leads to a different treatment regimen than for that of TB infection. Now, how and when specimens are collected and when the test is carried out depends on the workflow in your settings, but should be considered and optimized to avoid unnecessary follow-up visits for clients. In principle, a positive TB infection test should lead to the initiation of TB treatment, while a negative test should not, though there might be circumstances where you would repeat your infection test. So the handbook also contains a schematic flowchart on how to implement the TB infection test. The first step includes the identification of target populations that are eligible for TB preventive treatment. And I'm sure you know all about it now after Dennis's presentation. This is, of course, country dependent. Yeah. When screening for people presumed to have TB disease and further diagnostic testing, it's advised to use more accurate method like chest X-ray to increase the sensitivity of the screening, just to be sure that you don't miss any persons with TB disease that then would proceed to TB infection treatment. WHO advises that the TB infection tests, the TST, the TBSTs, or the IGRAS, is initiated on the same visit for the individuals that you have identified as being eligible, since the testing procedure stretches over 1 to 2 days of these tests, and you want to avoid losing those eligible for testing. After the appropriate testing time, the infection tests should be evaluated and decision should be taken whether TPT should be initiated or not. And then after initiation of TPT, the person is, of course, followed up and monitored, and finally outcomes of the treatment is reported and recorded. So to the Annex 1, that includes a detailed description of how to administer the skin tests, whether it's the TST or the TBSTs. The procedures are similar for these 2 types of tests, so you can use it for either. The detailed description that you find here in Annex 1 it's a detailed description of the test procedure and should provide a good template for the development of SOPs in your countries. And finally, the Annex 2, that provides detailed descriptions of the 3 IGRAS that are presently recommended by the WHO. It's the quantiferon plus, the TB IGRA, and the T-spot TB tests. All the tests require incubation for up to 24 hours, hence commencing the procedure on the first visit of the clients does save time to diagnosis and decreases the risk of loss to follow-up. After incubation, an ELISA is performed to develop and read the results, meaning that the good lab infrastructure and skilled staff are necessary, as I mentioned earlier. So these detailed descriptions do not replace the package inserts of the different tests, but it gives the reader a detailed understanding of the procedures and could hopefully guide national TB programs in selecting the test of their preference. So I also have some photos of the knowledge sharing platform, but Dennis already mentioned it, so I'll jump to the future. So for the moment, WHO Global TB Program is working on the 4th edition of the Module 3 diagnosis, both the guidelines and the handbook. The new edition is a result of the guideline development group that was held this spring, and will be a consolidation of the documents on diagnosis and on tests for TB infection. So there won't be 2 books anymore, but only 1. No new recommendations during this meeting were made on TB infection tests, so they will all stay the same. But it will include recommendations for the use of LF-LAM among people living with HIV, and also on concurrent testing with multiple tests for certain groups. The rapid communication for this will be published very soon, and the full guidelines and the handbook are expected to be published in early 2025. So that's all I wanted to say today. Thank you very much, and I am, of course, prepared to answer to any questions. Over.
Thank you very much, Carmen. Comentarles a los participantes que está colocado en el chat del enlace para acceder a los documentos y las presentaciones que se están haciendo esta mañana. Les animamos también a que escriban sus preguntas en la sección de Question and Answers, por favor, para los panelistas puedan responder a sus inquietudes también. Comentarles que disponemos ya de rifa argentina y vamos a dar paso a la siguiente sección que está en la agenda de integración con las preguntas por parte de los participantes. Tenemos una pregunta para, creo que puede ser Denis, para este caso para Denis. Si la pregunta dice si la rifampicina ya puede ser usada en menores de 12 años.
So the question, I think, is about rifampicin use as a TPT, right?
Yeah.
Not for as part of the shorter HPMZ regimen for treatment.
The part of TPT.
TPT. Yeah, so rifampicin now, the 3HP, right? The 3HP regimen can be used down to the age of, or the weight of 3 kilos. So practically childbirth, right? Newborn kids. So that can be used. For 1 HP, we do not yet have a recommendation to use it below the age of 13. And that is because there's still some discussion about the appropriate daily dose of rifampicin in children. So the weekly dose, however, has been modeled, and you will see that information in this annex of the handbook, which gives you a summary of so it can be used below the age of 12, the age of 2, of course, and yeah, thanks.
Thank you, Dennis. Another question. ¿Hasta cuántas veces se puede prescribir tratamiento preventivo de tuberculosis en una persona y con qué periodicidad?
Yes, that is a very good question and very often asked. Actually, I mean, there is no restriction on the number of times that you give TPT in the same person. The question is really, is it effective, right? Does it add benefits to that individual person? So there is very little evidence for now to show that, that repeating TPT would give benefit. There is one trial that has looked in people living with HIV taking 2 successive sort of treatments or 3HP, which did not show added benefit. But nonetheless, if there is someone who has had TPT in the past and who has had a fresh exposure and is significant, right? from, let's say, someone who's very infectious, contact with someone who's very infectious, then there could be another reason to give TPT. But the evidence over there is still low in terms of doing it in that situation.
Otra pregunta que tenemos, Denis, también. ¿Qué opina sobre el uso de PPD en mayores de 5 años? En contacto mayores de 5 años.
So ideally in that group, one would do one of these tests that Charlie has explained in order to ascertain that that there is infection, right, in that person, and act on the result of that test. So very often, if it's a very recent exposure, then if you do a test for infection, it might not yet be positive. So, and some clinicians would want to repeat that after a few weeks to see if there is a change in the status, and then act on the result of the second test. However, if the tests of TB infection are not available, we advise that people should not deprive persons who have been significantly exposed, living in the same household, let's say, with someone who is infectious and coughing, they should not be deprived of having TPT. So you can give TPT in the absence of a result of tests of TB infection in contacts aged 5 and older. In the younger age groups, the benefit always sort of overcomes the possible risk, and that is why we do not advise that one waits until you have a result from a test before you give, because in that group, the risk of getting TB and of progression is very high. So we advise that you do not wait and you go ahead. Same as for people with HIV.
Gracias, Denis. Creo que esto es muy importante que acaba de mencionar Denis también y recalcar. Entonces, en estos grupos, si no hay disponibilidad de PPD, esto no debe restringir tampoco la selección o la administración de terapia de tratamiento preventivo de tuberculosis luego de descartar una enfermedad activa. Tenemos una nueva pregunta, en este caso, Charlie. Por favor, las pruebas cutáneas de antígenos recomendadas actualmente han sido aprobadas por agencias reguladoras. Sí. Y hay una segunda pregunta aquí, si es que estas ya están disponibles en el mercado y si es que se van a incluir en el catálogo del GDR.
Yes, so there are 3 TB skin tests that are recommended by the WHO. So it's the CyTB from India, the Diaskin from Russia, and the CTST from China. Now, these are the recommendations from the Global TB Program, so from WHO Global TB Program. The next step is that these tests should undergo some regulatory evaluation. And the WHO PQ is working on this, but they haven't reached there yet. So they haven't started evaluating and approving any of the skin tests. But the Global Fund has a function called the Expert Review Panel, the ERP. And the ERP has approved the Indian CyTB test. So that one is available also to purchase if you use your global fund grants, if you have those. But none of them have yet been approved by any regulatory authority, as I know, in any specific countries. And of course, the WPQ has not reviewed and approved or disapproved them. So the only thing you have to stand on now is the recommendations from the Global TB Program, which traditionally has been enough for the using the global fund grants or for purchasing by governments. So in principle, they are available. Now, the Indian test is probably the one that is available in the easiest way, so to see. The Russian test is obviously difficult to buy now, as the situation is in Russia, and the Chinese tests is not that easily available on the market, though it is a marketed product, so it's possible to purchase. Though I'm not sure how you do that. I would need to look into that more deeply. Over.
Thank you, Charlie. Tenemos otra pregunta para Denis. Denis, ¿cuál es el riesgo de administrar tratamiento preventivo de tuberculosis en una persona que tenga signos o síntomas muy leves de tuberculosis o que aún esté en una fase subclínica?
So here we're talking about the risk, if I'm understanding well, right? The risk of giving TPT to someone who has minimal sort of symptoms of disease. Is that the question?
Yes, so subclinical.
Okay. Subclinical, okay. Yeah, well, I mean, we don't have evidence that this is going to predispose that person to let's say to emergence of drug resistance or else to untreated TB. But of course, based on the principles that we always observe, is that if someone has TB disease, then they should give a full TB treatment. Then one should avoid a situation such as this where you do not want to undertreat someone, right? In that case, probably it's better that there is a full investigation, a more aggressive investigation for disease before you make a decision to give TPT. If it turns out that it's maybe some other condition that's mimicking TB symptoms, then one would give TPT. Otherwise, you would consider, of course, giving full treatment. We will have actually a discussion with experts coming up in a few weeks' time, which will look at sort of subclinical TB itself, because it's an interesting condition that's becoming topical in the discussion of the TB community, to see whether it is time now to define subclinical TB clearly for programs, and whether, which should be the main research areas in terms of diagnostics, in particular in terms of treatment, as you rightly mentioned, based on the public health implications of the condition for the individual patient, and also for, let's say, transmission of TB in those people. So this is coming up as well. So maybe in future we will have trials set up so that they investigate different types of regimens for subclinical TB.
Thank you, Dennis. La siguiente pregunta para Michael, si se encuentran en camino nuevos métodos de diagnóstico de infección.
I mean, the methods that I presented today are the methods to diagnose TB infection. So the short answer is yes, there are a few tests. I mean, the TST is a test that will diagnose TB infection. You will have to exclude TB disease before you do that. So it doesn't distinguish between TB disease and TB infection, since if you have TB disease, you have the infections. But when you have excluded TB in a careful way, then your TST or your TB skin tests or your eyeglass will detect TB infection. I'm not sure if I understood the question correctly.
Yes, it's fine. Hay otra pregunta en relación, Denis, por favor, esta pregunta para ti. Si una persona está recibiendo tratamiento preventivo para tuberculosis y se suspende durante el curso, ¿cuánto tiempo después se puede volver a reiniciar?
Okay, so we have in the new handbook, there will be a table which will give some indications about interruptions and when you decide whether you can continue the treatment, right, the original treatment, or else you have to stop it and restart the same treatment or another treatment. So there are thresholds which are put over there and which are informed by practices that have been used in trials. So what criteria trials used, right, to decide whether if there is an interruption in a person who's on the trial, when do they start or stop the treatment. So in essence, one would aim to have that within the expected period of the regimen, let's say if it is 6 months, that you would receive at least 80% of the expected doses, right? If it's 6 months or 3 months or 1 month. And if you can complete the regimen by increasing that period of time by 1/3, so let's say if it's a 6-month treatment, you push it up to 8 months, right? If you can complete the treatment within those extra 2 months, then you can continue the treatment. If you feel that, if you see that it's not going to be possible, right, one of the criteria is not met, then you should consider restarting the treatment itself. So again, these are criteria that are based on from trials. So we don't have exact sort of evidence about failures of TPT with different modalities of or durations of interruption, but they give some indication. And we have a table which shows you for each regimen more or less the number of doses to tolerate to continue the treatment.
Thank you very much, Dennis. Next question for Charlie. ¿Desde qué edad se recomienda la aplicación de IGRA? O sea, si es que se puede usar IGRA en niños pequeños. Si es que hay alguna interferencia con vacuna, puede explicar un poco esta situación.
Yeah, so there is no interference with the vaccine, so you can use it on BCG vaccinated persons. And for children, you can use it for children as well. As Dennis mentioned, there is no reason to use it on children less than 5, since the recommendation is to start TPT anyway. So for children 5 and above, you can use the IGRA test.
Gracias, Charlie. Bien, vamos a tomar una última pregunta para luego continuar con la agenda prevista en esta mañana. Y la pregunta tiene relación, esto es también para Charlie. Si pacientes que usarán biológicos en el caso de enfermedades autoinmunes, solamente la condición de tener una enfermedad autoinmune es suficiente para administrar TPT, o se debe descartar o se debe hacer el diagnóstico de infección tuberculosa.
Do you think you could repeat the question?
Maybe. Maybe I can answer that. So there is a recommendation on the use of TPT in people who are on or starting anti-TNF treatment. For other forms of biologicals, there's probably some risk as well. It has not been as well documented as it is with anti-TNF, because anti-TNF has been used more widely and for longer than some of the newer biologicals. So it would be, I think in some of the product inserts of the newer biologicals, they do mention the importance of exclusion of TB and the use of the potential use of TPT in situations where these people would need to be tested, of course, and then on the result of the test, both chest X-ray usually and the test of TB infection acting on that test.
Gracias, Denis. Sí, hay una pregunta sobre el uso de rifampicina en todos los grupos de edad. Recalcar que sí, está indicado. Y quisiera pedirle a Denis también si es que podemos ampliar un poco sobre el uso de la rifampicina en las personas con VIH como tratamiento preventivo.
So rifampicin-based regimens, right? Both 1 HP and 3. Sorry?
Yes.
You hear me? Okay. So both rifampicin-based regimens, right, for TPT are recommended in people with HIV and are probably some of the best treatment that they can receive. So I think it's important that efforts are made to expand the use of rifampicin-based regimens in people living with HIV. There is again in the new handbook, there's again commentary about the concomitant use of rifampicin with dolutegravir, and up to now, at least the evidence does not show in favor of increasing the dose of dolutegravir in order to achieve the same viral load suppression in people who are having 3 HP and 1 HP. It is important, of course, that we keep monitoring the literature to see where it is going, but for the time being, our experts have not come in favor of proposing an increased dose of a doubling of the dose of dolutegravir when using rifampicin. So again, if you're using rifampicin-based regimens, then that's a different story, right? For people living with HIV and dolutegravir.
Muchísimas gracias nuevamente, Denis y a Charlie, por las excelentes presentaciones. Y creo que se han despejado muchas de las inquietudes que se presentan en el día a día en las personas que están atendiendo a los enfermos con tuberculosis. Creo que este apoyo que nos brindan es importante. Esperamos también que hayan quedado claras las respuestas para las personas que tenían las inquietudes. Podemos seguir también haciendo preguntas, les animamos a que sigan escribiendo y podemos responder posteriormente también vía correo o quedarán puestas también en la grabación posteriormente las respuestas a las preguntas que no se hayan colocado aquí, que ustedes las vayan colocando posteriormente. El siguiente punto en la agenda es, ya una vez que hemos visto todo este panorama, ¿cierto? Es mirar cuáles son las experiencias que se han generado ya en la región en relación con la búsqueda de contactos y tratamiento preventivo de tuberculosis. En relación con esto, queremos pedir a Brasil, por favor, que muestre a la región cuál es la experiencia que ellos han ido generando durante este tiempo y dispone de un tiempo de 20 minutos. Adelante, Daniel, por favor.
Olá, vocês me ouvem? Sim?
Escuchamos.
Eu estou com problema para escutá-los. Sim. Estão ouvindo? Tá. Bueno, então, buenos dias. Se me permitem, prefiro hablar português por questões de tempo, só tenho 20 minutos. Então, meu nome é Daniele Hort, eu trabalho no Ministério da Saúde do Brasil, na coordenação de tuberculose, e quero agradecer por esse convite, né, por a invitação, por estar aqui hoje nesta webinar. E agradeço também em nome do Programa Nacional de Tuberculose. Eu vou compartilhar a tela, só um minuto. ¿Están viendo?
Estamos viendo, sí, también tenemos algunas dificultades con el audio. Se puede ver, puedes ponerla en modo presentación y continuar.
Foi?
Perfecto.
Deu certo? Ok. Então, eu trago para vocês um pouco sobre a busca de contatos, e o tratamento preventivo da tuberculose no Brasil. Vou apresentar algumas atividades, né, que estão acontecendo no país, para que a gente possa intensificar a prevenção da tuberculose no Brasil. Este é o cenário mundial. O Brasil hoje é o único país das Américas presente em 2 listas de países prioritários para a OMS, né? E se encontra a tuberculose ativa e também a infecção tuberculose VIH. O Brasil é um país continental, então representa aproximadamente 1/3 de todos os casos de tuberculose nas Américas. No ano passado, em 2023, nós tivemos mais de 80.000 casos novos de tuberculose. Temos 72% dos 5.500 municípios com ao menos um caso de tuberculose e 14.000 estabelecimentos de saúde com ao menos uma pessoa com diagnóstico de tuberculose. Este é o coeficiente de incidência, né, e número de casos novos de tuberculose no Brasil de 2003 a 2023. Nesta gráfica, observa-se em 2020 a queda da incidência no país, em decorrência da pandemia, tudo leva a acreditar, e depois, nos anos seguintes, a gente também consegue visualizar o aumento da incidência. Em 2023, chegou a quase 40% de tuberculose por 100.000 habitantes no país. E isso mostra, né, esse dado nos mostra o quão é importante a gente fazer o rastreio, né, das pessoas, fazer avaliação de contatos, visto que o aumento da incidência, o aumento do número de casos chegou a 40%. A mortalidade no país hoje se encontra com 2,7%, aumentou também em decorrência do período pandêmico. Esse percentual quase que se iguala a um percentual de mais ou menos 20 anos atrás, né, o 2002. Estratégias estão sendo realizadas no país, no Brasil, como visitas aos estados para realizar oficinas do óbito para entender melhor esse dado. Esse dado de 2022, o dado de 2023 ainda está sendo avaliado, ainda há um incremento, pode ser que em 2023 a gente tenha um valor mais aumentado desse número de óbitos. Então, sobre os objetivos do tratamento preventivo, né? A realização do tratamento, a prevenção da tuberculose deve ser feita em pessoas para desenvolver as pessoas que não têm recentemente infectadas entre 2 e 5 anos, e também nos contatos de pessoas com tuberculose, as pessoas vivendo com HIV, VIH, os profissionais de saúde e os profissionais de saúde. E também pelo alto risco de desenvolver a enfermidade, a tuberculose, são as pessoas vivendo com HIV, com VIH, pessoas que recebem terapias imunossupressoras e pessoas em realização de hemodiálise e pessoas com silicose e outros fatores de risco também. Então, sobre a busca dos contatos hoje, como que nós estamos trabalhando no país? A gente deve buscar essas pessoas para evitar sempre o aumento da cadeia de transmissão da doença. Então, o que nós fazemos hoje, identificação e avaliação desses contatos. A porta de entrada para esses contatos hoje é a atenção primária à saúde, é a porta de entrada principal, é para onde chegam os nossos pacientes no serviço. Os profissionais devem se organizar para fazer a identificação e tratar essas pessoas com tuberculose e infecção tuberculosas. Ações programáticas também são pensadas e realizadas pelos programas de tuberculose e os serviços também da rede de atenção à saúde para que essas ações sejam efetivadas. E também o diagnóstico da tuberculose na atenção secundária e estabelecimentos de referência. Ou seja, as pessoas que têm uma indicação por algum efeito colateral, efeito adverso, ou pessoas que têm tuberculose resistente, elas devem conter um fluxo bem estabelecido para que essas pessoas sejam direcionadas. Então, é muito importante o papel dos profissionais de saúde nessa situação e também dos enfermeiros para que essas ações sejam, de fato, efetivadas. E como fazer a avaliação de contatos? É feita por realização de anamnese, exame físico, exames complementares dos contatos e de acordo com a presença ou ausência de sintomas. Então, os contatos assintomáticos, geralmente, as pessoas que não têm sintomas de tuberculose, elas são encaminhadas no serviço de saúde para realização de exames bacteriológicos ou exames laboratoriais, e descartar a TB ativa ou não. Contatos assintomáticos, os profissionais devem descartar a tuberculose ativa e diagnosticar a infecção latente para um possível tratamento preventivo da tuberculose. E as pessoas também que são assintomáticas vivendo com VIH, descartar também a tuberculose em atividade e fazer o tratamento preventivo da tuberculose. E quais são as estratégias para buscar a infecção latente em pessoas vivendo com HIV, com VIH? É o rastreamento sistêmico da tuberculose a partir dos 4 sintomas, que deve ser realizado em todas as visitas das pessoas vivendo com VIH, em todo o serviço de saúde. Se há um ou mais sintomas, deve-se investigar a tuberculose e, se não há sintomas, avaliar a possibilidade de tratamento preventivo nessas pessoas que têm vivendo com VIH. O diagnóstico no país da infecção tuberculosa se dá por 2 métodos hoje, por prova tuberculínica, que é a prova cutânea de la tuberculina, e a prova de sangue, que é o IGRA. É proporcionado pelo Sistema Único de Saúde, não tem custo nenhum para a pessoa e se oferece o serviço de atenção primária, em especial. A prova tuberculínica está indicada para todas as pessoas, em geral, e os ensaios de interferogama IGRA, eles são indicados para algumas populações, hoje, e futuramente o Brasil pretende ampliar para todas as pessoas em geral. Essas pessoas que são beneficiadas hoje com o IGRA são as pessoas vivendo com VIH, uso de imunobiológicos ou imunossupressores, pré-transplantes de órgãos sólidos e células-tronco. Nas crianças, ninhos, contatos de tuberculose pulmonar ou laríngea, entre 2 e 10 anos. A prova tuberculínica, a interpretação do registro, ela se dá em milímetros, a leitura. Uma prova tuberculínica maior ou igual a 5 milímetros, que corresponde à população geral, ou prova tuberculínica maior igual a 10 milímetros é indicado no país para profissionais de saúde e outras categorias, se considera positivo para a infecção tuberculose. E prova tuberculínica menor que 5 milímetros se considera negativo para a infecção tuberculose. O IGRA, se positivo, é infecção tuberculose presente, se negativo, infecção tuberculose ausente. E indeterminado, recomenda-se repetir o teste. Sobre o tratamento preventivo da tuberculose, onde estamos e para onde vamos. Então, esse é um breve histórico de que, antigamente, lá no passado, por volta de 1994, a gente utilizava um esquema terapêutico de 12 meses com isoniazida, um tratamento longo, né, com baixa adesão. Depois de estudos de meta-análise e reuniões com os pesquisadores, a gente conseguiu chegar nos 9 meses com isoniazida. Depois, por indicação da OMS, Organização Mundial da Saúde, passamos a também oferecer esse tratamento preventivo durante 6 meses. Logo após 4 meses de tratamento com rifampicina, e hoje estamos na atual situação utilizando em todo o país o tratamento encurtado com 3-HP, rifampicina mais isoniazida, desde o ano de 2022. E hoje, recentemente, há 2 meses, conseguimos incorporar no Sistema Único de Saúde o tratamento 3RH para crianças, ninhos, menores de 10 anos de idade, com peso entre 4 e 25 quilogramas, com dificuldade de deglutir. São medicamentos dispersíveis e estamos utilizando no país há 2 meses. Todos os estados, as unidades federadas do país, já recebem esse esquema terapêutico para as crianças. E, por último, estamos em fase de pesquisa e implantação sobre o 1-HP. Ainda estamos trabalhando para que conseguimos implantar esse tratamento mais encurtado ainda. É bem provável que começaremos os estudos a aplicar esse tratamento na população mais vulnerável. Estamos pensando em fazer em privados de liberdade, prisioneiros, na porta de saída. Mas ainda é um desejo e as perspectivas são para os próximos meses. A nossa cobertura hoje de tratamento preventivo, essa gráfica mostra o número de pessoas que iniciaram o tratamento da tuberculose, preventivo da tuberculose, segundo o esquema terapêutico. Então, de agosto de 2021 a abril de 2024, a gente tem um total ali de utilização no nosso sistema de 4.208. Antes era usado estavam no acréscimo da isoniazida. Hoje a isoniazida era um pouco menos ofertada devido às capacitações e também o estímulo para que os estados e as unidades façam o tratamento com rifampicina. Então, a gente tem aí uma queda, né, evidente aí nesse gráfico, em setembro de 2023, e isso a gente pensa que pode ser devido ao desabastecimento que houve no período do PPD, né, da prova tuberculínica no país, e mostra aí que a oferta está sendo boa e a gente pretende estimular, continuar realizando capacitações para que as pessoas indiquem mais o tratamento com a rifampicina e isoniazida como um tratamento de primeira escolha, principalmente para as pessoas vivendo com VIH. Essa gráfica está linkado com outro sobre o tratamento preventivo por unidade federativa. Então, isto mostra o uso da rifampicina mais isoniazida nos estados, nas unidades federadas do país. Ainda se usa bastante a isoniazida, né, mas a rifampicina está sendo bem ofertada como um tratamento de primeira escolha. a proporção das pessoas que iniciaram o tratamento preventivo segundo a situação de encerramento. A gente tem um dado de quase 80% do país fazendo o tratamento preventivo com 3-HP. A gente sabe que é um tratamento que reduz o abandono, né, aumenta a adesão, aumenta os desfechos, né, de cura, de reação adversa, dentre outros. Atualmente, nós temos alguns esquemas terapêuticos disponíveis no país. São esses que eu apresentei agora há pouco no histórico. Então, todos eles têm as indicações, né, de acordo com os anos de idade da pessoa ou da criança, do ninho, o tempo de tratamento, tanto para rifampicina com isoniazida, quanto para rifampicina com isoniazida, o 4R ou 6H ou 9HR. Esse tratamento depende também não só do número não só dos meses, mas sim dos números de doses tomadas do tratamento preventivo e o tempo também de conclusão desse tratamento preventivo, de acordo com as indicações terapêuticas. São algumas situações especiais, ou seja, que tem algum tipo de tratamento diferenciado. Então, as mulheres grávidas, né, embarazadas, sugere adiantar o tratamento, adiar o tratamento para depois do parto, porque estudos mostram que o risco é menor para a gestante. Se a mulher, né, vive com VIH, é aconselhado tratar depois do 3º mês, com o uso também de medicamento para evitar hepatotoxicidade. Nas pessoas vivendo com VIH, quando pode também ser ofertado raio-x, né, raio-x de tórax, quando o raio-x normal e CD4 menor, contagem de células de CD4 menor que 350, independentemente da prova tuberculina do IGRA ou quando tem um CD4 desconhecido, então é recomendado que se faça o tratamento preventivo da tuberculose, descartando 100% a tuberculose em atividade. CD4 menor de 350 células, com prova tuberculínica maior que 5 milímetros, ou IGRA positivo. Também é recomendado que faça tratamento preventivo. Contato intradomiciliar ou institucional com tuberculose ou pulmonar ou laríngea, independentemente do resultado da prova tuberculínica ou do IGRA. E registro documentado de ter prova tuberculínica maior ou igual a 5 milímetros, ou do IGRA positivo, e não ter recebido tratamento da tuberculose. Além da radiografia de tórax com cicatriz radiológica de tuberculose, sem tratamento anterior para a tuberculose, independentemente do resultado da prova tuberculina. Nesse caso de registro documentado, de contato intradomiciliar não institucional com tuberculose ou pulmonar ou laríngea, isso se dá pelo acesso. Às vezes a pessoa pede a oportunidade de realizar tratamento por alguma situação ou por dificuldade no acesso, então também é recomendado fazer tratamento preventivo. E também os contatos de tuberculose resistente. Então, as pessoas que têm tuberculose XDR ou MDR, hoje a gente recomenda só acompanhamento, né? A gente acompanha aí no período de mais ou menos 2 anos, por enquanto, porque essa pessoa a gente precisa pegar ela, se ela tiver uma tuberculose ativa, a gente precisa diagnosticar recentemente. Ou outra resistência, né? É importante avaliar a possibilidade de utilizar rifampicina ou isoniazida. Então, se a pessoa tem outra resistência, que não é o XDR ou MDR, a avaliação é sobre a utilização de rifampicina ou isoniazida. Esse é o segmento do tratamento preventivo, é recomendado consultas mensais. Sempre nessas consultas é importante avaliar os sinais e sintomas da tuberculose durante esse tratamento, que a pessoa ela pode evoluir para a tuberculose ativa, e descontinuar se a pessoa tiver algum marcador enzimático alterado, né? 5 vezes ou mais do limite de normalidade. Então, é importante e é recomendado que se descontinue esse tratamento. Além disso, né, é preferencial fazer, no país a gente orienta que seja esquema preferencial com o uso da isoniazida mais rifampicina e também é recomendado que se faça em regime de tratamento diretamente observado, devido à rifampicina. Se é TDO, se não for possível a realização do TDO, outras estratégias de adesão devem ser conversadas e todos os esforços nas unidades de saúde devem ser tomados para que essa pessoa tenha uma boa adesão do tratamento. Quanto à perda de segmento com o uso da rifampicina e isoniazida no país, se caracteriza 3 doses consecutivas ou não. Com a rifampicina, se caracteriza 60 dias consecutivos ou não a perda de segmento. Com a isoniazida, 90 dias consecutivos ou não. E com rifampicina mais isoniazida, 60 dias também consecutivos ou não. E se a pessoa perder nesse prazo, é aconselhado retomar o tratamento preventivo da tuberculose. Os algoritmos de decisão do Ministério da Saúde. Então, eu trouxe para vocês aqui uma nota informativa que vocês podem ter acesso, é uma nota recente, é uma nota que traz 4 algoritmos importantes para investigação e rastreio. Eu não trouxe aqui todos os fluxos, porque senão a apresentação ia ficar muito extensa. Então, essa nota conta com os algoritmos de diagnóstico da LTB em contatos adultos e adolescentes maiores de 10 anos, nas crianças menores de 10, algoritmos também para profissionais com possibilidade de exposição ocupacional à tuberculose, e também em pessoas vivendo com VIH e em situação de pré-transplante de órgão ou células-tronco, ou uso de terapia imunossupressora. Então, o link vocês podem ter acesso para apreciar o nosso fluxo. É importante frisar aqui que existe hoje essa nota, né? Essa nota que eu acabei de falar, contendo os fluxos, ela veio à luz do parecer técnico favorável de 2023, onde mostra, né, que o enfermeiro ele pode solicitar provas diagnósticas de infecção tuberculosa e indicar tratamento preventivo da tuberculose. Isso é uma novidade no país. Esse documento teve esse parecer favorável em abril do ano passado e hoje estamos em fase de capacitação no país para que os enfermeiros possam prescrever tratamento preventivo, visto que a categoria profissional da enfermagem é a maior força de trabalho no país e os enfermeiros têm total potencial e capacidade para nos apoiar aí nessa luta e intensificação das ações de prevenção da tuberculose. Então, o Conselho Federal de Enfermagem aprovou esse documento, onde legaliza o enfermeiro a realizar também o diagnóstico com o IGRA, né, já era feito antes, mas isso ficou registrado em nota técnica e também nos documentos do Conselho Federal de Enfermagem, e também a fazer prescrição de tratamento preventivo. O Ministério da Saúde hoje tem esses fluxos para que o enfermeiro possa ter segurança nessa indicação e também os estados e os municípios possam elaborar seus protocolos locais frente às suas necessidades locais hoje em dia para que essa indicação seja realizada com sucesso no serviço de saúde. E quais são os desafios para melhorar? Então, suministro contínuo da prova tuberculínica cutânea da tuberculose e formar profissionais para aplicação a leitura e interpretação da prova tuberculínica. Hoje, no país, nós temos um banco de instrutores e também um banco de pessoas que são multiplicadoras da prova tuberculínica. Nós estamos em um processo de capacitação na rotina do serviço de saúde. Também temos alguns manuais em fase de revisão, sobre prova tuberculínica. Então, hoje o país e os estados contam com ao menos duas a três pessoas no seu estado ou município realizando prova tuberculínica no país, e também fazendo a replicação, a multiplicação nos seus serviços e também no seu município. Levar a cabo toda a cascata de atenção em um só lugar, né? Todo o tratamento seja realizado em um só lugar. A radiografia de tórax disponível para investigação da tuberculose ativa, incorporação de novas tecnologias como o CAD, como foi dito aqui um pouco mais, a gente não tem ainda no país, mas a gente tem uma perspectiva muito boa para adquirir e implantar. Segmento e aplicação das recomendações nacionais para os profissionais de saúde na rotina do serviço de saúde, notificação no sistema de informação IUTB, que é o nosso sistema de controle e acompanhamento dos casos que iniciaram o tratamento preventivo das pessoas em tratamento. E quais são as estratégias de vigilância da infecção pelo micobactério. Hoje a gente tem esse manual de 2019, ele está em fase de revisão. É bem provável que esse ano ou no próximo ano ele esteja concluído com as revisões atuais. A gente trabalha à luz desse manual, o protocolo de vigilância da infecção latente da tuberculose. Essa é a segunda edição, a primeira edição foi em 2018, essa edição de 2022. Esse manual traz todas as recomendações, diretrizes para notificação e controle dos casos de tratamento preventivo. E todas as nossas estratégias, ela está alinhadas com as recomendações da OMS pelo fim da tuberculose. Esse outro manual é o nosso Plano Nacional pelo Fim da Tuberculose, onde tem ali no pilar 1 a intensificação das ações de prevenção de tuberculose. Esse é a vigilância da tuberculose, o protocolo publicado em 2018, que eu acabei de falar. Esse é o rostinho, né, a imagem do nosso sistema de informação IUTB. Lá tem as pessoas que fazem tratamento, que iniciaram, estão em tratamento de infecção latente. É um sistema, uma ação descentralizada. Ela começou a ser implantada no país em 2018, em 5 estados. Depois a gente deu continuidade em 2019 nos demais estados e finalizamos essa implantação em todo o país em 2021. Então, hoje, todo o país, todas as unidades federadas tiveram a capacitação e todas as pessoas das unidades, a maioria dos profissionais, têm acesso a esse sistema hoje, onde conseguimos ter esse controle das pessoas em tratamento, também um controle melhor aí da dispensação dos medicamentos do tratamento preventivo da tuberculose. Bom, graças, obrigada pela oportunidade e fico disponível com as perguntas.
Muchas gracias, Daniel, por tu presentación y por compartir esta valiosa experiencia también de Brasil. Seguro que esto va a servir de inspiración a los demás países de la región y además se demuestra que es factible realizarlo en la región. Comentarles también a los participantes que las preguntas se están respondiendo también vía chat y seguiremos respondiendo conforme vayan llegando. Así que les animamos a que nos sigan enviando sus preguntas. Por lo pronto tenemos 2 preguntas que haremos posteriormente a Daniel, pero antes quisiera dar el paso a la doctora Gabriela Maya, del PNT de Uruguay, para que nos presente también esta experiencia que ellos han generado en el país, y al final haremos entonces la sección de preguntas mientras ustedes se van animando a escribirlas también. Adelante, por favor, Gabriela.
Buen día para todos. Bueno, inicialmente agradecer a OPS por la invitación y por esta posibilidad de compartirles la experiencia que tenemos en Uruguay en relación a la búsqueda de contactos y al cambio en las guías que hemos tenido en el último año de acuerdo a las últimas recomendaciones que hemos tenido de OPS. y de OMS. ¿Se ve la presentación allí? Perfecto. Bueno, muy bien. Solo a modo de presentación, Uruguay está ahí, el país de América del Sur, un pequeño país ubicado entre Argentina y Brasil, con una superficie de 176.000 kilómetros y casi 3,5 millones de habitantes, con un índice de Gini de 0,39. Con respecto a la tuberculosis, para el año 2023 fueron notificados 1.350 casos. Esto determinó una tasa de incidencia de 36 casos por 100.000 habitantes y están bien identificados en relación a los grupos de riesgo que los contactos presentan una tasa de incidencia de tuberculosis una vez estudiados de 5.900 cada 100.000. Esto es lo que demuestra la importancia de ser nuestro principal grupo de riesgo para el diagnóstico de tuberculosis. A partir de las recomendaciones del año 2020 de la Organización Mundial de la Salud, es que comenzamos a pensar cómo íbamos a incorporar estos nuevos cambios tanto en el diagnóstico de infección como en las nuevas opciones de tratamiento preventivo para la tuberculosis. Y es así que en el año 2021 comenzamos a preguntarnos desde el Programa Nacional de Tuberculosis en qué condiciones está Uruguay para poder realizar este cambio. Uruguay tiene algunas particularidades que diferencian a otros programas de la región en relación a la atención a la tuberculosis y a los contactos, ya que las actividades de pesquisa de infección tuberculosa y de enfermedad activa se realizan en forma centralizada en la Comisión Horaria para la Lucha Antituberculosa, que es donde se desarrolla el Programa Nacional de Tuberculosis a nivel de todo el territorio nacional. Ahí ven todos los departamentos de nuestro país, en donde la lucha antituberculosa está en todos ellos, con asistencia directa hacia los pacientes. Hay 43 centros de la lucha distribuidos en los 19 departamentos. Entonces contábamos con una capacidad instalada en todo el territorio nacional. Teníamos capacidad para adquirir los nuevos fármacos, es decir, incorporar la rifampicina, que era el fármaco que debíamos incorporar para hacer el cambio en la TPT. Después de un análisis de costos, de logística, de abastecimiento y de distribución, se llega a la decisión de que teníamos la capacidad para incorporarlo. Teníamos vasta experiencia en tratamiento directamente observado y tratamiento observado por video, que ya habíamos generado desde el año 2020 la incorporación de la supervisión mediante bots. Había capacidad de seguimiento y personal capacitado y comprometido tanto en la realización de las pruebas diagnósticas de infección tuberculosa como para el seguimiento, aplicación de las terapias preventivas. Es así que en el año 2022 se decide comenzar con el proceso del cambio preventivo de la tuberculosis, que nosotros teníamos basado en el esquema de 6 meses diario de isoniazida autoadministrado, y ahora íbamos a pasar a los esquemas acortados recomendados por la OMS y lo íbamos a implementar en los grupos de riesgo para desarrollar tuberculosis. Es así que en el 2022 se decide realizar una prueba piloto a nivel nacional, y esto formaba parte de este cambio de la terapia preventiva, para lo cual se decide realizar una investigación operativa en el contexto de esta prueba piloto para ver la factibilidad de la incorporación del esquema y de su expansión a nivel nacional. Se adquiere la rifampicina por la unidad de fármacos, se selecciona la población a la que se va a aplicar este nuevo esquema, y estos son los contactos de pacientes con tuberculosis pulmonar y a las personas que viven con VIH. Se seleccionaron los centros periféricos en donde se iba a realizar la prueba piloto y se seleccionan 11 centros periféricos de acuerdo a la tasa de tuberculosis que presentaban en el territorio, a la posibilidad de seguimiento y a que tuvieran atención tanto de población adulta como pediátrica. Así que durante el año 2022 y principio de 2023 se realiza esta prueba piloto y por lo tanto la investigación operativa, que era un estudio de factibilidad. Los objetivos de este estudio de factibilidad era específicamente evaluar la factibilidad técnica y operativa de la introducción del esquema cortado con rifampicina y isoniazida, el esquema 3HP para el tratamiento de infección tuberculosa en Uruguay, y como objetivos específicos, porque ya había mucha evidencia demostrada, nosotros nos planteamos estimar la incidencia de reacciones adversas, la adherencia al tratamiento y comparar tanto adherencia como reacciones adversas de los dos esquemas. El que aplicábamos en el plan piloto, el esquema 3HP, y compararlo con el esquema clásico que realizábamos de 6 meses de isoniazida. Y por otra parte, sumar además la opinión del personal de salud que implementa el plan piloto. La metodología de esta investigación operativa a nivel programático: se realiza un diseño metodológico mixto, un enfoque cuantitativo y cualitativo. Acá, a modo de resumen y solo para traerle algunos números, el enfoque cuantitativo se realizó mediante un ensayo clínico no aleatorizado, multicéntrico, en esos 11 centros periféricos que les comentaba. Se realiza el seguimiento longitudinal y prospectivo de las dos cohortes. En los 11 centros, los que ingresaron al tratamiento supervisado con 3HP, con un N de 256, y comparado con la otra cohorte que recibía el esquema clásico con isoniazida durante 6 meses, autoadministrada, con un N de 474. Y a modo de resumen, los resultados que voy a traer principalmente es los que tienen más significancia estadística, y es en la evaluación del tratamiento. Vemos que la finalización del tratamiento hubo gran diferencia en ambas cohortes. La cohorte que recibió el esquema 3HP tuvo un 73% de tratamiento finalizado versus 48% con la cohorte que recibió la isoniazida por 6 meses, y esto muestra una diferencia significativa. Lo mismo que
Gabriela, no sé si se nos quedó congelada tu pantalla, no sé si nos estás escuchando. Pedimos por un momento a Gabriela mientras ella se conecta.
Podríamos pasar a una pregunta.
Tal vez mientras recuperamos la conexión con Gabriela, podemos pasar a responder una pregunta por parte de Brasil. Daniel, por favor. Hay una pregunta que está colocada en nuestro chat, donde pide que si se puede aclarar un poco. Ya. Gabriela, te recuperamos.
Sí, perdón, no sé qué pasó, se desconectó solo.
Si ¿quieres puedes apagar tu cámara a lo mejor para mejorar la conexión? Volvernos a compartir nuevamente la pantalla.
Creo que me quedé ahí, ¿puede ser?
Es una antes de esto.
Perfecto. En la anterior lo que les estaba comentando es las diferencias en el resultado del tratamiento en cuanto a la finalización y a la pérdida de seguimiento. Pero aparecía un nuevo grupo que tenía que ver con la suspensión del tratamiento y era mayor en el grupo 3HP. Cuando fuimos a analizar un poco esto, vimos que las diferencias tenían que ver sobre todo en si estábamos hablando de población de adultos o de niños, y la suspensión del tratamiento se vio en el 22% de los niños. Las causas de esta suspensión tenían principalmente que ver, en un 82% de los casos, con la dificultad en la ingesta. Y eso nos lleva a pensar principalmente una de estas situaciones que tenía que ver con que en los niños teníamos que adecuar un poco este tratamiento, ya que no se conseguía precisamente que completaran el tratamiento y tenían necesidad de suspenderlo. Lo otro importante que pudimos obtener de esta investigación operativa es el estudio cualitativo que realizamos, que era la encuesta que se realizó a todos los funcionarios de los 11 centros que participaron del plan piloto, y luego hicimos entrevistas a las encargadas de estos centros del plan piloto. De los resultados de esta encuesta, vimos que la percepción en cuanto a la aceptación del tratamiento por parte de los pacientes, el 83% consideraba que era buena y muy buena. En cuanto a las dificultades de implementación, uno tenía que ver con la adquisición de los alimentos. Recordemos que el esquema 3HP, sobre todo por la rifapentina, tiene una mejor absorción si se encuentra relacionada con una ingesta previa de alimentos, y como nosotros estábamos haciendo una supervisión de este tratamiento, una de las dificultades que se encontraron ahí era adquirir los alimentos precisamente para que la ingesta fuera no en ayunas. Acceso a los exámenes paraclínicos, teníamos usuarios del subsector privado con costos para realizar los estudios, por ejemplo, los funcional hepáticos para hacer el seguimiento de los mismos. Y después pudimos identificar ventajas y desventajas. Ellos manifestaban que las ventajas era el tratamiento corto y la frecuencia semanal y la posibilidad de seguimiento supervisado, ya que permitía un contacto y apoyar precisamente esa adherencia de mejor forma, así como pesquisar la posibilidad de efectos adversos. Y en cuanto a las desventajas, lo contaban principalmente a nivel de los niños, que tenía que ver con el número de comprimidos en comparación con el esquema clásico y con las formulaciones, que no contábamos con formulaciones dispersables, sobre todo para los niños más pequeños. Es así que después de esta investigación operativa, en el año 2023, publicamos las nuevas guías para prevención de la tuberculosis, y que fueron dos. Una relacionada al control de contactos y otra para el diagnóstico y tratamiento de la infección tuberculosa en condiciones de inmunosupresión, que incluye a los pacientes VIH, a los pacientes que están por recibir fármacos inmunosupresores, principalmente anti-TNA-alfa, y para pacientes que están candidatos a trasplantes de órganos. Enfocándonos en la guía de control de contactos, se explicitan todas las acciones a desarrollar en el control de contactos, se plantean los objetivos del mismo, que son interrumpir de forma satisfactoria la transmisión de la tuberculosis y prevenir futuros casos y brotes de enfermedad, teniendo como premisa que los casos de tuberculosis comenzaron como un contacto. Ahí en la cascada de atención en el control de contactos podemos ver tres escalones bien claros. Uno tiene que ver con la identificación, el segundo con el estudio, que es inicialmente para la búsqueda de tuberculosis activa y para realizar el diagnóstico de infección tuberculosa, y finalmente el paso 3, el tratamiento y las opciones de tratamiento preventivo. En cuanto a la identificación de contactos, las guías dividen los contactos iguales o mayores de 15 años de los menores. En los casos mayores de 15 años, se considera contacto cuando el caso índice de tuberculosis pulmonar puede ser confirmada bacteriológicamente o clínicamente diagnosticada, y en todos esos contactos se va a realizar la búsqueda activa y el diagnóstico de infección tuberculosa. Y en los menores de 15 años se va a proceder a la búsqueda activa y a la identificación de cualquier, siendo contacto de cualquier caso índice de tuberculosis, independientemente de la localización o la confirmación bacteriológica. Asimismo, se prioriza el estudio de estos contactos de acuerdo a si estamos en un nivel de riesgo mayor, los contactos domiciliarios, o niveles de riesgos menores, si tienen que ver con contactos institucionales o laborales. El segundo paso de la cascada es el estudio mediante el diagnóstico, la búsqueda de tuberculosis activa, que se realiza mediante radiografía de tórax, baciloscopías y expert ultra, tanto en niños como en pacientes con situaciones de inmunosupresión. Y por otro lado, el diagnóstico de la infección tuberculosa se realiza mediante la prueba de PPD, y el punto de corte utilizado es mayor a 5 milímetros para indicación de tratamiento preventivo en todos los grupos etarios, y en los menores de 5 años va a ser independientemente del valor del PPD del cual se prescinde. En el caso de que la prueba inicial de PPD sea menor de 5 milímetros, como estamos en estudio de contactos y se presume un contacto reciente, se espera 12 semanas y se repite la prueba para considerar nuevamente, si presenta más de 5 milímetros, tener indicación de tratamiento preventivo de la tuberculosis. Finalmente, el tercer paso de esta cascada corresponde al tratamiento preventivo, y teniendo en cuenta en parte los resultados que habíamos obtenido de la investigación operativa, realizamos dos esquemas, uno recomendado para adultos y otro para niños, para menores de 15 años. El esquema para adultos de primera instancia es el esquema 3HP, es decir, isoniazida rifapentina, una vez por semana por 12 semanas, y supervisado. A partir del año 2023 ya contamos con las dosis fijas combinadas del esquema 3HP, y en términos generales la indicación de 3 comprimidos en personas con peso igual o mayor a 50 kilos y menores de 50 años, y tener en cuenta además que se requiere un seguimiento y unos estudios, como por ejemplo el funcionar enzimograma hepático a nivel inicial y mensual, los controles médicos mensuales, la administración con alimentos, el recordatorio de interacciones farmacológicas y la adición de vitamina B6 en caso de pacientes con diabetes, alcoholistas y enfermedad renal crónica. Como segunda opción de tratamiento y priorizando los esquemas acortados en base a rifamicinas, se dispone de rifampicina diaria durante 4 meses autoadministrada y como tercera opción de tratamiento la isoniazida por 6 meses. La terapia preventiva en el caso de los niños o los menores de 15 años los vamos a dividir en primera opción y alternativas, siempre priorizando la disponibilidad de los fármacos que tenemos en el país y de acuerdo a la evidencia disponible hasta ese momento. Los menores de 2 años, como ustedes saben, no estaba recomendada la rifapentina, que ahora vimos como novedad que apareció para todas las edades. En los menores de 2 años, la primera opción, la rifampicina durante 4 meses, porque teníamos formulación jarabe. Entre 2 y 9 años, isoniazida rifampicina durante 3 meses, utilizando las dosis fijas combinadas dispersables. En los niños de 10 a 14 años, sí el esquema 3HP en dosis individuales, tal como lo recomienda la OMS, y pusimos la salvedad de utilizar dosis fijas combinadas de acuerdo al peso de estos niños y a indicaciones individuales. Los esquemas alternativos también van a priorizar los esquemas acortados en base a rifamicinas y sobre todo la utilización de formulaciones amigables en niños. Y acá poníamos como importante contar con presentaciones para rifapentina y isoniazida dispersables, que como vimos en las presentaciones ya van a estar disponibles a la brevedad y ver de poder optar por estas opciones que son amigables con los niños y mucho más efectivas. Bueno, y esto era todo para comentarles en relación a la experiencia que hizo el país. En el año 2024 ya está incorporado el esquema 3HP y todos los cambios que se hicieron en las nuevas guías a nivel nacional en todos los centros para toda la población, tanto como contactos, como poblaciones con VIH o poblaciones con otras situaciones de inmunosupresión. Muchas gracias.
Gracias, Gabriela, por la presentación. Sí, los resultados que han mostrado también de la investigación operativa de Uruguay y recalcar también todos los participantes, ¿no es cierto?, que esto fue realizado en un entorno de una investigación operativa que el país la hizo en su momento y recalcar también que en la actualidad las guías recomiendan o lo que se estipula en las guías, ¿no es cierto?, para la implementación y la expansión del tratamiento preventivo para tuberculosis, no requiere también ya de una investigación operativa actualmente, ¿no? Entonces, eso, tenerlo presente y pensar en cómo el país va a implementar y va a expandir el tratamiento de los grupos de acuerdo a todas las indicaciones que se han ido visualizando durante esta jornada de trabajo. El siguiente punto contemplado en la agenda entonces tiene que ver en relación con las preguntas que se realicen a nuestras dos expositoras sobre la experiencia. Y quisiera mencionar, tengo 2 preguntas que se escribieron para el caso de Brasil. A Daniel, por favor, si es que se puede ampliar un poco lo que se mencionó sobre el tratamiento preventivo en personas privadas de libertad. ¿Cómo lo hicieron?
Desculpa, qual foi a pergunta sobre os privados de liberdade? Tá, no histórico que eu apresentei, né, na linha do tempo do tratamento preventivo, hoje, atualmente, estamos oferecendo no país o esquema 3HP, que é a rifampicina mais isoniazida. Esse esquema é o mais encurtado e é o de primeira escolha no país. E hoje a gente está com um 3RH também para criança, que são os dispersíveis. O que eu falei do 1HP é o esquema de 1 mês, é o esquema, ainda está em estudo no país, é um desejo do Brasil implantar esse esquema terapêutico, e o que eu falei é que a gente pretende iniciar para as populações mais vulneráveis. e, a princípio, na população privada de liberdade, os prisioneiros, quando estiver saindo da sua condição prisional. Tá? Então, ainda não é uma orientação para o futuro, a gente ainda está em estudos e pesquisa para organizar no país como que será essa estratégia. Tá? Ainda é um desejo, ainda não é algo real neste momento.
Muchas gracias, Daniel, por tu respuesta y comentar también a los participantes que específicamente sobre este tema de uso de tratamiento preventivo en personas privadas de libertad tendrá un espacio específico. Estamos planificando un webinar para las próximas semanas donde se hablará muy ampliamente sobre este tema. Hay una segunda pregunta también, Daniel, es en el caso de las embarazadas. ¿Cómo hicieron ustedes? Parece que no se entendió muy bien si lo necesitaron antes ou depois do parto, da pergunta.
Sim, para gestante, a gente recomenda postergar, para pessoa embaraçada, o Brasil está recomendando postergar o tratamento preventivo para após o parto, porque a gente reconhece que o risco de ter tuberculose quando a gestante não tem comorbidade, está bem, é bem menor. Então, a gente recomenda que ela tenha o bebê, laninho primeiramente, para depois iniciar o tratamento preventivo, porque não é uma emergência. Seria uma emergência, um tratamento da tuberculose, por exemplo. Mas, gestante, a pessoa embaraçada, se tiver vivendo com VIH, aí sim recomenda-se tratar após o 3º mês de gestação, porque o risco é aumentado dela ter uma tuberculose ativa, certo? Então, recomendamos apenas quando tem VIH para que faça o tratamento preventivo após o 3º mês de gestação. ¿Listo?
Gracias, Daniel. Y quisiera aprovechar también la presencia de Denis en el webinar para pedirle un poco también una ampliación sobre este tema, sobre el uso del TPT en embarazadas.
¿Es otra pregunta? Disculpa.
Por ahora tenemos esas dos preguntas. Muchas gracias. Muchas gracias por tu presentación. Bien, insistimos nuevamente que se animen a continuar escribiendo. Nosotros iremos respondiendo las preguntas también en el transcurso conforme vayan llegando. Creo que con esto llegamos al final de este webinar y quisiera dar paso al doctor Pedro Abedillo, asesor regional de prevención y control de tuberculosis.
Bueno, muchísimas gracias, Francisco. Primero de todo, agradecer a los colegas, a Denise, a Charlie, de OMS, también Daniele, Gabriela, de los programas de Brasil y de Uruguay. De verdad, muchas gracias por estar hoy con nosotros, muchas gracias por compartir sus experiencias y todo el conocimiento que tienen. También agradecer a los colegas, a los traductores y, por supuesto, a todo el equipo aquí regional que ha estado trabajando en la preparación del webinar. Solo recordarles que vamos a compartir las grabaciones de este webinar, al igual que el de los previos, las presentaciones en inglés y en español, que las tenemos traducidas. Vamos a enviar también por mail, pero saben que tenemos ese espacio en la web de OPS donde estamos almacenando todo el material relacionado con los webinars y con los temas de búsqueda activa y tratamiento preventivo. Invitarles igualmente a continuar consultando las guías de OMS, seguir consultando las guías de OMS, los cursos online que tenemos traducidos en español, el de tratamiento preventivo y también el de diagnóstico. Estamos trabajando con el equipo de Ginebra en la traducción de más de los cursos. Tienen mucha información para responder a las preguntas que hoy se han estado realizando, que sabemos que son preguntas que recibimos en todas las sesiones sobre los grupos que deben recibirlo, sobre el uso del PPD o de los SIGRAS, las reacciones adversas, los esquemas de tratamiento. También vamos a comunicarles en breve las siguientes fechas que tenemos para los próximos webinars, que como estábamos hablando, quisiéramos profundizar sobre el tema de tratamiento preventivo en personas con VIH y también queremos hablar sobre búsqueda activa y tratamiento preventivo en otros grupos de riesgo, principalmente pensando en privados de la libertad. Entonces, ya como mensajes finales, colegas, recordar que necesitamos expandir el tratamiento preventivo, la investigación de contactos. Tenemos todavía coberturas muy bajas, oportunidades de mejora importante. También no solo los contactos de todas las edades, también contactos más allá del domicilio y otros grupos de riesgo que conocen, personas con VIH, otras personas con inmunocomprometidos, privados de libertad, personas con adicciones, migrantes que vienen de países de alta carga y recordar que afortunadamente tenemos disponibles herramientas que nos pueden facilitar todo este proceso, ¿no? Más herramientas para descartar enfermedad activa, para administrar con más seguridad el tratamiento preventivo, como el uso de la radiografía digital y ECA que hablábamos, pero también recordar algunos aspectos importantes que se han discutido durante el webinar. No necesitamos en los grupos de riesgo, dado el alto riesgo que tienen de evolucionar la enfermedad, el diagnóstico con PPD, el diagnóstico de la infección latente con PPD o IGRA no debe ser una barrera para poder dar el tratamiento preventivo en los grupos de mayor riesgo, ¿no? Tenemos que centrarnos en descartar la enfermedad activa y si no tenemos las herramientas para el diagnóstico de la infección, necesitamos seguir adelante con el tratamiento preventivo. Tratamiento preventivo que saben, conocen bien, que tenemos también esquemas más seguros, más cómodos para indicarlos, pero también mucho más cómodos para tomarlos. Veíamos las experiencias de los dos países, cómo se aumenta, cómo se expande el uso y cómo tienen mejores resultados de adherencia que los esquemas más largos. Y también recordar que necesitamos coordinar e involucrar a otros profesionales, ¿no? Como decíamos, solo con los médicos y solo con los programas de tuberculosis no vamos a lograr esa expansión del tratamiento preventivo. Hemos visto la experiencia de Brasil, incluyendo al personal de enfermería para expandir la indicación de tratamiento preventivo, pero también tenemos que pensar en otros programas que están en atención primaria, en concreto en el primer nivel de atención, con inmunizaciones, con salud materno-infantil, con los programas que están trabajando en nutrición, por supuesto con otros sectores, pensando en privados de libertad, otros sectores que puedan estar en contacto con las personas migrantes y también con la sociedad civil y la comunidad, ¿no? Necesitamos ese trabajo colaborativo conjunto para de verdad conseguir la expansión de esta intervención, de esta herramienta que es imprescindible para acelerar los esfuerzos hacia la eliminación. Yo con esto finalizamos, agradecerles de verdad a todos por su participación, por su tiempo y les deseamos que tengan muy buen día. Seguimos en contacto.